So good morning, everyone. The topic given to me is not a core microbiology topic, but I'll try to justify it to my best of my potential. So the topic given to me is Phage-Bacterial linkage in infections and SDP prophylaxis in cirrhosis. So basically, I'll be discussing about it's known fact that bacteria, they are obviously metabolome, metagenome, that is important in cirrhosis, progression, outcome, mortality, everything is related. So as you know that progression of cirrhosis is often associated with development of bacterial infection, which in turn result in poor prognosis because of organ failure and antibiotic resistance. And there is a specific evidence that there is a changes in gut microbiota, including bacteria and phages, that they could be associated with a negative outcome. And major determinant of bacterial and phage interaction and the potentiator of resistance infection is prior use of antibiotic. Now, there are several studies which have been published. This one is 2021 gastroenterology, which shows that alteration in gut microbiome in cirrhotic is definitely going to make a difference in the outcome, 90-day mortality, and the functional change. As we can see, as the disease progresses from healthy to compensated to decompensated to ACLF, you can see there are two graphs are there. One is the gene percentage. So gene percentage gradually, as you can see here, in this we can see that the gene richness basically of the gut decreases. As the disease progresses, the gene richness of the gut reduces. At the same time, species richness also reduces as the disease progresses. It's a known fact that there is a definite alteration of the gut flora as the disease progresses. So now there is something called as, so about this bacteria, it is a known fact, but now something called as phage. Now phage, as you may be knowing that phages are the viruses infecting bacteria. They can undergo lytic cycle or lysogenic cycle. So lytic phages are those phages which will ultimately kill the bacteria, whereas lysogenic phages are those which can provide some additional property to the bacteria, which can be good or bad for the humans. So now the study has been done in 2017, and it was, and the whole of the phagome, there's a term called as phagome. So phagome was coined. It was said that the human gut has 3 different set of phages. So there are some phages which are universally present in all human across the globe, and there are those phages which are present in all the humans, they are called as core bacteriophage. So core bacteriophage are shared by more than 50%, and then after core we have something called as common set bacteriophage, which are present in around 51 cases. Then we have individual bacteriophage which are present in individual, and it is said that the core bacteriophage and the common set of bacteriophage, they form the human healthy gut phagome, and the alteration in this phagome is definitely important, now implicated is a cause of various issues. Now it is well known that it is already various studies have been published where it is shown that phages has been described in uninfected patients with cirrhosis, as well as in patients with pre-cirrhotic liver disease and alcohol-associated hepatitis. This is one of the studies in 2020 in hepatology, in which it was shown that the patient who are having alcoholic liver disease and alcoholic hepatitis, they have several phages which are absent in the healthy controls, like phage like Escherichia phage, Enterobacteria phage, Enterococcus phage. They were over represented in fecal sample from patients with alcoholic hepatitis. At the same time, those who are having a severe disease, in them additionally phages specific to Staphylococcus phage and herpes viridae viruses, they were seen in those patients who are having severe alcoholic hepatitis, and these are related with the severity and 90-day mortality as well. So now we know that both bacteria as well as phages, they are responsible for in some way they are implicated in the causation of cirrhosis and disease progression and ultimately outcome. So now this is a new concept. Now what is the integration between the bacterial genome and virome? So here the word virome means phagome. So how they integrate in different conditions and what is the ultimate outcome? So there are very little data available, very skewed, very little. In fact, I could hardly find 2 or 3 studies. So in one of the studies what they have studies about interaction of bacterial metagenome and virome in patients with cirrhosis and hepatic NCAF. So in that they have said that although this phages have no role to play in progression of cirrhosis, but this phage bacteria interaction has a role to play in patients who develop hepatic encephalopathy, because there is a axis between the bacteria which produce ammonia, urease and ammonia, which will further enhance the NCAF. So now this is the one article which I could find in 2022. So this is the impact of bacterial infection and spontaneous bacterial peritonitis prophylaxis on phage bacterial dynamics in cirrhotics. So this is what So now, as you can see, there are 5 things are here. So basically, there's this one is a bacteria, and this yellow ones are the phages, and these are the linkages. So linkages, so blue ones is a negative linkage, and the red one is a positive linkage. So as you can see that there are 5 subset of patient. So one is the patient who is only having ascites, cirrhotic with ascites. So this is a minimal linkage and this is a negative linkage. Now second case you can say that this is a uninfected patient, and infected patient you can see there are cross linkages between the bacteria and the phages, and most of them are negative linkages, and further things become more complex as you go further, the things become more focalized. These are the patient who are on SB prophylaxis, and these are the patient, as you can see that there are a lot of, as you see that the phages population also increase and the crosstalk also increase, both negative and positive crosstalk between the bacteria and the phages. So things become more complex, and finally in SBP infection there is also crosstalk between them. So the red one, as I have told you, the red one, red edge positive and blue is negative. So these are all kind of influence between the bacteria and the phages in the gut. As the disease progression, the dynamic become more complex and more.
What do you mean by negative and positive here?
So positive means that they are somehow helpful in promoting that particular association is something beneficial, and negative means it is not beneficial, but there is an interaction, negative interaction or positive interaction which is happening. Like we'll discuss some of the phages. Phages have a positive impact, negative impact. Positive impact means those phages will help the bacteria to develop the antibiotic resistance. And negative phage means these phages can be lytic phages, which can kill the bacteria. So in this study, they have divided a patient into 3 subgroups: ascitic without SBP prophylaxis or current SBP. Then second group is ascites on SBP prophylaxis, and third group is ascites with current SBP infection. So 3 subsets have been given. So in these subsets, they have discussed about 2 basically bacteria. So as you know that in patient with cirrhosis, the 2 most common infections are UTI and SBP. And the commonest organism responsible for these conditions are in gram positive, we have Enterococcus, in gram negative, we have E. coli. So they have further now tried to characterize the interaction between these 2 bacteria with the phage in uninfected cases. I'll discuss about the interaction between these phages and the bacteria infected, uninfected patient, and also I'll discuss the interaction between these 2 bacteria in patient who are on SBP prophylaxis and patient who are not on prophylaxis, and thirdly who are having SBP. So this is a thing you can see. So in the center you can see that this is a Enterococcus, and the green ones are the phages, and this red ones are the bacteria, and the blue lines mean negative. So as you can see that in unaffected patient, Enterococcus faecium was negatively linked to several, these are all commensal bacteria, negatively linked to commensal bacteria and only to 2 phages. These are the green ones are the phages. So this is an uninfected patient with cirrhotic. So when we come to the infected patient, so the network become more complex. As you can see, the red one is positive, blue one is negative. As you can see that the network is more complex. A positive correlation between Enterococcus faecium and gram-positive taxa was seen, whereas negative linkage was identified with commensal bacteria like Bacteroides and several other phages. So these are negative linkage and positive linkage. So interaction become more complex in patients who are having infection. And that is why the bacteria which develop, obviously, as has been observed in various studies, even before the antibiotic therapy, the bacteria, they are becoming antibiotic resistant, maybe because of the reason, because they already had a cross linkages happened. So they have acquired the phages which will help them in making either biofilm or developing resistance. So in E. coli, almost the same picture you can see. The center is E. coli. These are the commensal bacteria. These are the phages. Blue line are the other negative linkages. In E. coli, with negative linkages, a few phages and with commensal in uninfected patient. And you can see here, there's a Gauss change. So the complexity increases in infected patient, showing positive correlation with other member of Enterobacteriaceae family, Veillonella, and with 2 Escherichia phages. So these 2 phages are important because these 2 phages which they are having positive linkages, they are basically responsible for formation of biofilm, and they also impart the drug resistance to E. coli. And now this is basically patients who are basically, this slide is of patients who are on prophylaxis, SBP prophylaxis, or having ascites without prophylaxis, and third is who are having frank SBP. You can see the first one, the slide number A, you can see the E. coli subnetwork in patient with ascites showed only negative correlation with phages and gram-positive bacteria and positive linkage with other Enterobacteriaceae. constituent in slide A. So in slide B, in SBP prophylaxis, now this is the interesting thing, because when we give SBP prophylaxis to the patient, obviously the commonly Cipro and Norflox is being given. Although in this study they have committed that they have done only with the Ciproflox, and that too in the case of secondary bacterial prophylaxis they have given. And you can see that because it will suppress the growth of E. coli because of the antibiotic. Now the in case patient who are with prophylaxis, they are having strong positive correlation with other bacteria of the gut, which are predominantly pathogen, especially with the Streptococcus species. As you can see that this is the B1. So with SBP prophylaxis, there was a drastic reduction in complexity with positive linkage among gram-positive organisms, including some SBP-positive organisms like Streptococcus species and E. coli. So drastic change. That means after giving prophylaxis, things are not so positive as we used to presume. Things may become negative because when these people develop infection, so that will be probably more difficult to treat than those patients who have not received the SBP prophylaxis with. So although limitations are there in the study, they are limitation, but this is what they have concluded. And this shows the patient is having who is having SBP now. So you can see that it become a lot of jumbled up is there, and there's a lot of positive and negative things. Negative is mainly the commensal bacteria, which are the good bacteria. There's a negative linkage with bacterial bacteroides and parabacteroides, and Phage-1 and Phage-3 were positively linked. So Phage-1, P1 and PHI05 are the important phages for E. coli, which render them more virulent and more drug resistant. So similarly, in case of Enterococcus also, so the first one, A, B, and C. The first one is basically ascites with no SBP prophylaxis and no infection. You can see that there is a minimal interaction between the bacteria, and with only bacteroides, good bacteria, there is a minimal interaction. But the patient who is now on SBP prophylaxis, now you can see that network become more and more complex, more and more confusing, and there is a positive linkage between the patient who are having prophylaxis, the Enterococcus faecium with lactobacillus, negatively with commensal and potential short-chain fatty acid producing species, which are the good bacteria. So this is the link. This is the third one is basically infected patients. So these are who are having now SBP. So Enterococcus faecium was positively linked with Enterococcus. This is the most severe condition now, because now Enterococcus faecium, because of prophylaxis, it has grown and it has developed the positive linkage with the two very important phage, which make the Enterococcus more difficult to treat in patient who already had a SBP prophylaxis with the Ciproflox or Norflox. So this is the only one study which I could find where they have found out the interaction between the how does the phage and bacterial population changes in infected versus uninfected, and in patients who are in SBP prophylaxis and those who are not on SBP prophylaxis. So in conclusion, we can know that patient with cirrhotic who have a diagnosed infection have major alteration in gut bacterial microbiota and phage and phages as well, and phage bacterial correlation when compared with the uninfected patient. And SBP prophylaxis has a major impact on bacterial and phage composition and linkage when compared with those with ascites alone, and even with patients have developed SBP infection. And with bacterial metagenomic analysis, it was found that several pathobiont lactobacilli and oral origin taxa were significantly higher in infected patient even before giving the antibiotics. There is an alteration in the flora even before the antibiotic because of the interaction between the bacteria and the phage. And it was also seen in this study that there is a positive linkage between E. coli and various phages like Escherichia phage, PHIV1, which facilitate biofilm formation, which is critical virulence factor for E. coli, and PHI05 phage, which will contribute to the antibiotic resistance in Escherichia coli infection. Whereas in Enterococcus faecium, the primary linkage was positive with other gram-positive pathobiont like Streptococcus pneumoniae, Enterococcus durans, and negative linkage with other phages. So the ascites without SBP prophylaxis group had a heterogeneous and diffuse network, as we have seen, unlike the SBP prophylaxis alone, which was compact only because of the suppression of E. coli, which was more compact and is like the network of characteristic found in patients who are already having SBP infection. So obviously, generally we know that bacteriophages are the new things. They are the new antibiotic drug resistance on the high. So it is now proposed that bacteriophages can be used as a selective treatment for killing bacteria. And there are several published studies that have shown that so bacteriophage therapy as a treatment option in transplant recipient and donors as well. But the role of bacteriophages in case of SB prophylaxis and in case of patient with cirrhotic to prevent infection is still long way to go. So that is what I could found in the literature about the correlation thing. And that is it about the presentation. Thank you so much.